Hello, and welcome to the Neurotransmitters, a podcast about everything related to clinical neurology with the goal of reducing your neurophobia. I'm fortunate to be joined today by Dr. Ethan Meltzer, a neurologist at the University of Texas. Thank you so much for joining me today. I really appreciate it.
Yeah, thank you for having me.
So, the reason I asked you on was you had this book come out earlier this year called, very appropriately, How to Think Like a Neurologist, which I really love that title. It's very on the nose, and it has just enough cheekiness. But tell me a little bit about kind of how you got started in neurology, and then what the path was that led you to kind of publishing this book.
Yeah, so my path to neurology, I guess it goes pretty far back. As a child, I was always interested in science, and eventually found my way to medicine. And the brain just fascinates me. It's as people say, it's the last frontier of medicine in the sense of there's so much that we don't yet know, and it's just something that I think is very easy for me to see and to get excited about. There's someone. I don't know if it's a saying or someone has told this to me once, but I really like it, which is that, neurology and I guess psychiatry as well, it's the only specialty in medicine where the organ actually tells you what's wrong, which I really like.
Yeah.
If someone, the liver can't speak to you, the heart can't speak to you, but you can actually ask the organ that is having the disease what it's experiencing, which I think is just wild.
That is. I'm going to steal that one.
Yeah. Yeah, I stole it from someone. I can't remember who, otherwise I would give the credit.
So you've been obviously, gone through training, fellowship, etc., and now you're teaching neurology yourself. And what was it that you saw when you're teaching new trainees about neurology that kind of led you to write an entire book on the subject?
Yeah. So the book, How to Think Like a Neurologist, is, it was really inspired by, what I think of as trying to really tap into what is really the challenge of neurology, or what is the skill that neurologists have. It doesn't exist in isolation, and obviously it's inspired by my own training and the people that I learned from. And I'll give a quick anecdote. So I got the privilege of attending one of the New England Journal CPC's grand rounds when I was a resident, where Dr. Marty Samuels was presented a case, and it was this case that was incredibly complex. Guy with a very complex medical history, and he's having essentially every known neurologic symptom to that can be described, and it's progressing very quickly over the course of about 3 weeks, and then he dies.
Oh, geez.
The only other information that was really relevant is there was an inflammatory spinal fluid, and he had some fever, but it's just this very, very, very quickly progressing syndrome. And I remember sitting in the audience, and they're reading this history, they're presenting him this history, like what you would read in the, what the paper actually looks like when it ends up getting published. And there's so much information, and at the end of it, he puts up a single slide where he's taking all of this and he says, this is a rapidly progressive fatal meningoencephalitis. And, it was, basically that, 5 or 6 words. He's taken about 1,000 words, made it into 5 or 6 words, and he says, this really probably can't be much else besides amoeba. And it was amoebic encephalitis. It's one of these things that looks like magic if you don't really know what he's doing. And so that was really kind of the basis of the book, is that shouldn't be magic. It should be something that seems attainable to trainees, to non-neurologists, which is, how does someone get this, 2 pages of information, distill it to 5 words, and then formulate a differential diagnosis based off of that? And I think that's really, when I think back about my training in residency, and, I learned lumbar punctures, you learn how to do Botox, you do learn discrete skills, but probably the most important skill I think I learned was how to get a history, get an exam, and then translate that into meaningful data
Yeah.
that defines a clinical syndrome, and then I can make a differential diagnosis. And it's something that really is not taught, I think, for the most part in earlier parts of medical training. Students are given, the exam question, and it already has distilled it. It's already defined the syndrome in the exam question. And then when they come to the wards, they
Right.
struggle because they aren't presented with that information already. So being able to generate that, I think that was really the impetus for the book.
Yeah. And one of the things I really like is your emphasis on, and I think this, you reference his book a couple times, Dr. Aaron Berkowitz's Clinical
Mm-hmm.
Neurology and
Yeah.
Neuroanatomy, which actually came out just before, a year or two before I took my boards. I used it for my anatomy review for board
Yeah.
exams,
Yeah.
which was great. But he talks about imaging negative neurology, which,
Mm-hmm.
I know there's, let's just say, neuro haters out there. And like, oh, what do we need to, do that? We can just get an MRI, right? But there are
Right.
so many things in neurology where the MRI, maybe it's a red herring or it doesn't tell you anything useful at
Yeah.
all. And, really drilling down on like the thought process. And if you would be so kind as to talk a little bit about kind of your approach to generating your neurologic differential diagnosis.
Yeah. It's very apt to bring up Aaron's book. I know him well, he was one of my attendings, right?
Yeah.
And so again, these ideas aren't in isolation, and so really the idea of the book was to try and codify it in a way that at least I hadn't seen before.
Mm-hmm.
And I think one of the little blurbs for the book is really trying to flip kind of the case narrative on its head,
Yeah.
where it's the case is not that's not what we're focused on. We're not, I tell the readers, this is not a book where you're going to be learning clinical diseases, hopefully not, because it's a lot of zebras, a lot of rare things that
Right.
really
Right.
aren't too relevant for most of medical training. And so the end payout is not necessarily getting it right. The end payout is the journey, is the way to get there.
Mm-hmm.
And so unlike a typical case book where the focus is on the actual pathology, if you looked at the book, the pathology, it's not necessarily a throwaway, but it's a small little paragraph
Mm-hmm.
for the most part at the end of any case. And really the meat of it is trying to define the clinical syndrome. And so, kind of going back to that and defining that term a little bit here, I think about it, it's the one-liner in the assessment for neurology. That's what I tell medical students when I'm rotating is, your neurology assessment, shouldn't be, 25-year-old comes in with a MCA stroke.
Mm-hmm.
That first line is, a 25-year-old comes on with an abrupt or acute or hyperacute, whatever term
Mm-hmm.
you want to use, acute onset of aphasia and right-sided weakness. And then your
Yes.
differential stems from that in terms of what the actual pathology is. And so a lot of the book talks about using the history, and particularly what I used of a term is the pace. Other people would use the word tempo, but essentially how quickly something comes on. And then also the localization, where within the neuraxis is it? And combining those two things is what I think of when I think of as the clinical syndrome. So, that's what, Marty did in that grand rounds is, rapidly progressive fatal meningoencephalitis.
Right.
It's, that's the syndrome. And there's no you don't necessarily need any sort of book knowledge. Now you need neuroanatomy knowledge,
Right.
of course. You need to go to get a history, so it's not that there aren't any skills that are needed, but you don't necessarily need to have an encyclopedic knowledge of every disease that's out there. If you can get the syndrome, you're probably about 95% of the way there in terms of the diagnosis.
Right. I think that's, a lot of the workup that sometimes you'll see, if there has been a workup before you are asked to see a patient, it seems almost haphazard in terms of like imaging obtained. Like I can't count how many times I've been asked to see someone who's been having like, difficulty walking or leg weakness or, quote unquote leg weakness. And there's a lumbar MRI on file.
Right.
I'm like,
Right.
well, that doesn't fit this presentation at all. Like that's just a wasted test. And so I somewhat ingest with the residents and students who work with me. It's like, sometimes part of the job is just telling people where to point the scanner.
Right. But to that point, I'll
Yeah.
give one anecdote. But to that point, when I think of value-based care,
Hmm.
especially in neurology,
Oh yeah.
and it's interesting, because we have these discussions often in our morning reports. There's a lot of value-based care there, right? Because it is, getting unnecessary tests, lab tests, MRIs has a huge cost, to the patient.
Hmm.
You have the potential for false diagnoses, and so, think about how many MRIs of the lumbar spine for difficulty walking could be avoided.
Right.
With a simple, what's the pace, what's the localization? Oh, that seems like Parkinsonism. Okay,
Right.
there's no need to look at the lumbar spine. And I have to make the comment just because it just happened this week, but I was, one of my proudest moments so far on Morning Report is one of our new PGY2s was presenting this case of this person who came, this woman who came in, and the ER had called him after they had ordered a MRI of the brain, cervical, thoracic spine, and he sees the patient. He says, "Well, has this kind of ascending paresthesias and hyporeflexia, a little bit
Yeah.
of minor hip flexor weakness." And he said, I told him, no, just we don't need to look there.
Yeah.
I really thought that this was a polyradiculopathy, and I thought,
Mm.
the
Nice.
future is bright. They're
It makes your heart
the next
swell.
generation of neurologists is still there, and so that sort of thing is makes me so proud when I hear our students
Yeah.
thinking like that, because they're generating hypotheses,
Hmm.
in the room, and then they're testing it,
Yeah.
with an MRI
And
or a
that,
lumbar puncture.
as the case may be. That's awesome.
Yeah.
Yes. So to your point, in terms of like, like you said, it almost seems like magic when like these
Hmm.
experienced attendings with decades of experience come in and see these patients. And there are a lot of medical schools out there that maybe their neuroscience courses are taught by more PhDs or non-clinical staff.
Hmm.
So they don't necessarily get that exposure to clinical neurology. And, I happen to work in an area that there's not, let's just say a dearth of neurologists as there are in many parts of the country. So for the trainees out there, other than just buying a copy of your book and using that with their neuroanatomy text,
Yeah.
what's the best way for them to try and get exposure to that, to get better feelings for that? What kind of resources would you recommend, or just calling local clinicians, which I know can be a little spotty
Yeah.
as well?
I mean, it's a huge challenge. I don't know if I have a great answer for you,
Yeah.
right? I mean, this is a problem everywhere. And correct me if I'm wrong. You might know the data. At least I think what the data is, it's about 1 in 50 medical students go into neurology.
Yeah. So actually,
Um,
I just saw a paper earlier this week, and
okay,
it was 2%. So you are right on the money.
okay, okay. Which I think that's kind of my observation as well.
Yeah.
And what's interesting to me is I've been in places where there are neurologists
Yeah.
are bountiful, they're
Right.
everywhere. Even then the ratio is not that different than
Right.
2%, or 1 in 50.
Right.
And so I guess that really begs the question. You asked a specific question which
Yeah.
I'm not answering just yet, or I
No.
haven't answered just yet.
Answer any question
But
you
what I
like.
would say is, even when there are neurologists around,
Yeah.
still that ratio, maybe it changes a little bit, but at least in my anecdotal experience, it's not too different. It's still close to 1 in 50. And so theoretically, those students are also seeing neurologists, they're getting that clinical exposure. They aren't having to go out of their way. It's actually being
Hmm.
put right in front of them. It's a core clerkship rotation.
Yeah.
And so that's still being missed. And so, I think, and people have written about that as well,
Right.
in terms of why, and that goes back to, some of those, original article on neurophobia back in, 1994,
Yeah. Yeah.
I think. But it's still a problem, I guess it's a problem that's been discussed for decades, and doesn't have a solution yet.
Yeah. And it's I think it's becoming a more and more pressing issue, just in terms of, there are treatments being developed for
Yeah.
neurologic issues.
Yeah.
And if there's no one to recognize the problem in a timely fashion and administer the appropriate treatments, then we're really missing the boat.
Yeah. Yeah, no, it's absolutely true. I mean, the percentage of the population that has neurologic diseases is only increasing,
Right.
just as we have an aging population.
Yeah.
It's simple math.
Right. But yeah, well, I guess I just raised more questions that we don't have answers to.
Yeah. I mean, I'm trying to think of a good answer back to your original question, which is, without it in front of you,
Hmm.
how do you improve that? And I think, that's the challenge is because when I think of, how to get students interested, to me, it's all about stimulating curiosity.
Hmm.
And I think, that's the shame about maybe neurology is that, that should be, it is objectively interesting. I have plenty of friends that are not
Right.
neurologists. They would never want to be a neurologist in practice, and that's okay. And, I wouldn't want to do what they do, and that's okay. Neither of us is wrong.
Yes.
But, neurology is objectively fascinating. And I think that that's one of the challenges I see sometimes is, when the focus, at least for some students coming in, is, I have to memorize some of the, the
Hmm.
brainstem stroke syndromes or the
Sure.
neuroanatomy seems very dense. It's hard to then see the relevance of that, see that in practice and see how powerful
Yeah.
that knowledge is. And so, when I have students on service, even the ones who don't want to be neurologists,
Hmm.
and they see a patient and they have this, opportunity to practice imaging negative neurology, which again,
Yes.
I love that term, right?
Yeah.
Where they go in the room and there's something that's unexpected and they come out and they say, that person, that was clonus,
Yeah.
and it's say, yeah, and they had weakness. And, I thought that was going to be a trapped nerve, but so, okay, so where's the clonus? And they kind of get there and say,
Hmm.
is this a spinal cord injury? And
Yeah.
and to see that connection happen, even for someone who, may want to do something very far removed from neurology in practice.
Hmm.
I think everybody is, I think everyone finds that fascinating. And I think maybe that's, it's not really the answer, but, the question, that's what I think of when I think of the medical school curriculum is we have to be showing students, what's really cool about neurology. And,
Yeah.
they may not become neurologists. That's okay, but it'll at least make them more willing to think about neurology because they're going to see patients with
Right.
neurologic diseases, right? And
Yeah.
that's that's the big challenge.
Right.
Is there so much overlap with other specialties, and people throw up their hands because they don't want to
Right.
try.
And you used a phrase actually one of my attendings used as well, the black box of the brain.
Yep.
And as soon as it's a neurologic issue, that's exactly what happens, right? It's like, oh well, that's probably gonna be complicated. I better just send to a neurologist. But then we run into that same problem again, right? Where it's a wait of like 3+ months, depending on what part of the
Mm-hmm.
country you're in. And you know we need internists and family physicians who are well versed in neurology because they are the frontline people. So yeah. How do you think, like, let's say we have a practicing physician out there, like an internist or
Mm-hmm.
a family doc. How could they best utilize this information here to guide their practice?
Yeah. That is a question I think I can answer. One thing I like to tell students and rotators when they're on service with me, as an example in terms of what I want them to get out of our time spent together, which
Hmm.
is usually too brief,
Right.
is, I give them the example of, if they're in the hospital and they have a patient and they think that patient has an acute abdomen. And I ask them, would you ever call the surgeon without ever having pushed on the belly? Or if you did call the surgeon without having pushed on the belly, what do you think their response would be on the, on the
Yeah.
other end of the phone? They wouldn't be acceptable not to try. And I think that to me is what I think about, for the book and what I think about when I work with them is what I want them to do is I want them to focus less on can they get the answer right,
Hmm.
but more can they go in the room and can they obtain the language, really be able to speak the language and be able to describe what they're seeing.
Hmm.
If someone's coming in and, and they're altered, right? We all,
Right.
as a neurologist, we all get these questions, oh, patient is altered. I don't need them to tell me what it is. I need them to
Yeah.
say, Miss Jones was, she was,
Yeah.
out playing bridge with her friends this morning.
Right.
And now she's lying in bed and she's asleep unless I'm constantly stimulating her.
Right.
Perfect.
Yeah.
You've really given me a lot of information about the acuity. And so I think, the book, is trying to get a little bit to that, which is to empower the reader
Yeah.
to say that even with just observation and being curious
Right.
and asking those questions, you actually get a ton of information that, that you should feel empowered to try and act on. That would be the next step in
Absolutely.
trying to get the diagnosis. But even getting that information makes you a better physician and makes you someone who will be more informed when you are asking for help.
Yeah. I think it's identifying what you're observing is a
Yes.
big piece of it. And like you said, we don't necessarily get trained in that on like the behavioral side of things as much as we probably should be. And that's exactly right. Like I always tell people on rounds, like, well, you don't have to like, spell world backwards for their mental status exams. Like, are like exactly like you're saying, like, do they fall asleep while you're talking to them? Like, do you have to keep shaking their shoulder the whole time? Just describe what you see. And yeah, it's really a struggle sometimes to get people to kind of break out of that, sort of mental rut that they're in.
Yes. So the book, it actually started as a lecture I gave medical students at the beginning of the clerkship. And I was asked to talk about, it wasn't, it wasn't anatomy. It was, kind of clinical case.
Yeah.
It was something. And that's where it came from. But, and it started with this disclaimer that I would give the students. These were small sessions, about 8 students. And I said, look, all of these are rare cases. And the likelihood is that no one in the room here knows the answer, or has it, and most of the time you've never even heard of the disease. And, not too many spoilers with the book, but there are things like, artery perturon stroke in there that,
Right.
Maybe some student happened to have heard in passing, but there's no way that they would have that on their mind, and they shouldn't.
Right.
But I tell them, because these are all rare and you're not going to get the answer, the intent is that it removes any sort of fear of standing up in front of the class and saying, and getting it wrong.
Right.
And that none of you will have it. And there's no reward to quickly going through the stem, looking for the, kind of the red flag words, buzzwords, and then trying to make that connection.
Right.
And so, the intent, this was again before the book even existed, was to have this lecture where we were doing these cases, and it was forcing the students to not try and guess the ultimate pathologic diagnosis based on the question stem, right? Based on the case presented. And so, that's kind of how it started in practice. And, and then I realized, actually, the students were really enjoying this. They were, it was something that was new that they really hadn't experienced yet. And, often at the beginning of the lecture, almost always they still try and do it. I'm circulating around, they're talking to little small groups, and I hear people saying, "Oh, aneurysm or something." No, stop. I'm not going to ask you if you think it's an aneurysm. I don't care about that. I'm going to ask you what you think the clinical syndrome was. But sure enough, within 5 or 10 minutes, they're really doing it, and I'm proving to them that they're actually essentially making the diagnosis. Rapidly progressive fatal meningeal encephalitis. They're putting that together, where they can just put it into Google and get the answer. And we often do that to prove to them that, actually they did get it right. Because, they're medical students. They do want to get it right.
Of course. That's what we're all programmed to do from the get-go.
Yeah,
right?
we're all programmed to do that.
But yeah, I really like, and one of the beautiful things about your book is that, there's, I think, like 40 some cases in here. And, each one, it's nice and digestible, and your writing style is very, very good. I very much enjoy it.
Oh, thank you.
But, if you even just have 10, 20 minutes, you can get through, at least 1 or 2 of these cases. So it's a great book to just have sitting on your desk and be like, even if you're not actively studying neurology, just, want a quick diversion. It's, I think, a great text for that.
No, it's not meant to be dense. It's meant to be something you can pick up, you can put down. It's meant to be, it's an adjunct. It's to, some sort of more dense neuroanatomy studying or disease studying. And it's supposed to be approachable. And I think that's really critical in neurology teaching. maybe getting a little bit back to some of the questions you asked before, which
Yeah.
is that, neurology it's hard.
Yeah.
And it's pretty humbling, even as someone who,
Yes.
now I'm an attending, I'm supposed to always know the answer. And I don't. Sometimes, people make mistakes, or you miss some subtle finding, or you get anchored on something. And neurology is hard. And I have this distinct recollection when I was at PGY2. I finished intern year. I'm pretty good at being an intern. Obviously I'm not, very, I've learned some medicine,
Right.
but I'm good at my job. And then I became a PGY2, and I thought, man, I am just getting my butt kicked. And just remember just feeling, wow, I didn't realize how much complexity there was to really trying to do this well. And I think that if we don't acknowledge that, now as someone, I guess, who's on the other side, we don't acknowledge that this is really a challenging field, and you can be the world's best neurologist and still not always get it right. That the book is supposed to be approachable, and that it's supposed to say, and you can see in the book, especially, the cases get a little bit harder as they go. Yes. There are times where the diagnosis wasn't clear, or the diagnosis is missed, and it's not because somebody was lazy. It's not because they were bad. It's just that, neurology can be challenging, and sometimes it takes a little bit of time to figure something out.
I know. I always feel like residents are frustrated when I say that. It's like, over time it will likely declare itself as of which of these things it is. And it's like, well, that's not very satisfying, is it?
Yeah, I say that as well.
Yeah.
I'm not too far out of training, and I think I need a few more gray hairs. When you have a lot of gray hairs, I think you can kind of sit back and you can, you can stroke your chin or something, and you can say that, and people don't roll their eyes as much.
Right.
But it's true, right? And I find myself saying that as well as, I really would love to have the answer now. We might just have to see this person come back and follow up in 3 months, and that will really tell us which way we're going.
Yes. And, to your earlier point, I too had an epilepsy attending in my fellowship who he would just say, it's such a humbling field because you're just wrong so often. Like your initial impression is just wrong. Like just this last week, another anecdote, I had a young woman come in for spells, and they'd been increasing in, the tempo was increasing, and they would be last just a couple minutes. She had a burning smell, but then she's like, I flutter my eyes, but I don't lose consciousness. I'm like, well, maybe it's something, maybe it's not, but they're happening almost daily. So I'm like, all right, we'll just put you on continuous EEG and we'll capture them. And I went into it fully expecting these to be, non-epileptic spells of some nature. And, I will be danged if they weren't epilepsy. And so I'm glad I did the workup and I didn't just, buy into my own assumptions. But yeah, it just goes to show that you're just wrong sometimes.
Yeah. Yeah. And I think that, it is something that I've noticed when students ask me about, how, why neurology, which is always a complicated question. But one thing I tell them is that, it's a bit of a personality test, right? If you want it to be very clear cut, black and white, get the answer right there, have a problem, then solve it or fix it. Neurology may not be for you. Okay, maybe interventional or, something a little bit more procedural. But, for the most part, if you're someone who really loves, the puzzle, right? I read lots of applications for neurology residency, the puzzle, the mystery, the logic of it. I think it takes a certain personality to say, that's really interesting and I want to figure that out.
Yeah.
And being okay that they may not, or that it might take some time to unravel it.
And there was, it's very apropos that you said that. There was a study just in the last couple of years that was looking at, they did language analysis of personal statements for neurology applicants. And the highest things that were most commonly seen were references to Sherlock Holmes and puzzle solving. And it really is there is a, sometimes stereotypes exist for a reason, right? And I think the stereotype of the neurologist does hold true in some respects.
No, it does. But that's what makes a good neurologist.
Yeah.
Again, you have to be curious. When somebody says something, you kind of have to have that, that kind of prickling sensation on the back of
Hmm.
your neck where you say, "Ooh,
Yeah.
what do they mean by that?"
I know.
I want to learn more.
Yes.
And I do that with the students. They have all these OSCEs, these
Hmm.
standardized things, and I try and tell them when I'm doing it in the hospital with them, I say, I don't need you to do these checklists. If
Hmm.
someone says something that you think is interesting, I just want you to stop and explore that. Spend as
Yeah.
much, if you think that there's something that's important, or they use a
Yeah.
word and you want them to explore it more, just focus on that.
Yeah.
Because the likelihood is that that's actually going to be much more relevant than asking the other parts of the review of systems.
Right. Yeah. I hate the review of systems. I think it's it's an artifact of billing, but
Yeah, yeah,
but yeah, and I do find, like, every once in a while there's like almost a sixth sense where you're sitting down talking with somebody, and then like you said, the hair on the back of your neck just goes up and be like, ooh, because you're like kind of sloshing back and forth between all these, like, how can I link all these disparate symptoms together? And then like one key phrase falls into your lap, and just like,
hmm
oh, and it just crystallizes in that, I don't know, it's a rush of like this epiphany where you're
yeah,
like, I'm hot on the trail now.
yeah, yeah. Yeah, I mean, I guess we've thrown out lots of anecdotes. I'll throw out another.
Yeah,
I
yeah.
was seeing this woman recently in clinic, and she had come to me. I guess part of my day job is I'm a neuroimmunologist, and so I
Hmm.
have an MS in neuroimmunology clinic, and a woman with MS, but she'd also carried this diagnosis of epilepsy and had these spells, and I
Hmm.
saw her the first visit, and I clearly didn't pick up on something. I hadn't probed it enough, and I
Hmm.
said, she was establishing care. I said, okay, so this long history, she had been having more spells. Let's get that EEG. Let's make sure that you're safe and you're on some anti-seizure medicines. So
Hmm.
that you're not having these things. And then she came back a few months later, and it's one of these things that I sat there after the visit. And I thought, what was different? How did I get such a different answer? And I realized in that second visit, these spells, these were all things that were happening only when she was very tired.
Mm.
And I think one of the differences was the husband was there to give some more
Oh yeah.
information, and we went on this whole path where it seemed like this was actually sound like a sleep disorder, and there were all these features of narcolepsy with
Yeah.
cataplexy, and it seemed and
Okay.
it went back to this pace and localization. Actually,
Yeah.
probably criminally type of case I didn't include in the book in terms of these kind of abrupt onset of neurologic symptoms would be sleep disorders.
Yeah.
So, spoiler alert: there's not a patient with a sleep disorder in the book, although there should be. And I was thinking back, and I thought, I completely missed it, because in my mind I had closed this syndrome when I was thinking about the syndrome of, okay, new onset of rather abrupt transient neurologic symptoms. I was, it's not
Yeah.
stroke, seizure, and she had this diagnosis of epilepsy. And then when I had really sat back, got a little bit more history, the husband was there to help out a little bit. I thought, oh, I've been completely blind to other things that can cause rather sudden loss of consciousness,
Yeah.
which would be she's asleep.
Right.
um, and so going back to the neurology is humbling, but
Yeah.
also with time you can figure it out. And so I kind of sat down and said, actually, everything we kind of spoke about,
Yeah.
let's not throw it out yet, but let's do some further investigation.
And I think that's a great point, especially for non-neurologists, right? We tend to think, obviously from our training, uh, people with certain types of neurologic issues, whether it's epilepsy or like, recrudescence of like stroke or MS
Yeah.
related symptoms, things like that, it's very stereotyped. But
hmm
if there's a change in the symptomatology or the events, that kind of, for us, raises red flags. But for other people, like you said, they could say like, oh, well, you've got the history of epilepsy, you're losing consciousness. I need no go. I don't need to go any further down that path
Right.
because we already know you have epilepsy. And like maybe they're having syncope, sleep disorders, the
Right.
list goes on. But yeah, I mean, that's a great point, is that we always have to be constantly reevaluating our diagnoses.
Yeah. And, you know, going on a tangent from that, but because you mentioned it,
Yeah.
one other thing I think about is how do we define what is neurologic and what is not neurologic,
Ooh,
right? Even in this
very
short conversation, we've
metaphysical.
mentioned things, like,
Yes.
non-epileptic seizures,
Right.
are those neurologic or non, we've talked about syncope, we've talked about sleep disorders. And
Hmm.
I think that's one of the challenges in our medical education when a lot of the medical education occurs in the hospital,
Hmm.
where there's an enrichment and disproportionate amount of seizure or stroke.
Right.
And then, as neurologists, we're very quick to say, sign off. This was syncope, this was not seizure, and our work here is done, and we'll pass this back. But does that fall within the realm of neurology? It's loss of blood flow. But there is brain dysfunction, and
Right.
often this is related to neurologic disorders. Is it autonomic
Right.
failure? And these other things. And I think that also is one challenge. I think I struggle with is
Hmm.
when I'm talking to students and even to our own residents. This idea of what we own as neurologists. What we
Right.
should be experts in, and what we don't need to worry about and don't need to be experts in. And if we are kind of shunning this and putting it to the side, then I think it makes us not as good as neurologists. I think it's
Hmm.
harder for the patient. But it probably exposes us to more errors, right? Because then we're just saying, oh, it's not a
Right.
seizure, so we can sign off,
Right.
which I think is dangerous.
Yeah, and you're absolutely right. Like, just to your point, right? Just this last week, I saw a gentleman who came in with syncope, right? But he has Parkinson's, so he needed his meds tweaked. Just because it's syncope
Right.
doesn't mean that there's not a neurologic component, or someone maybe with
Exactly.
a severe peripheral neuropathy who's having again some
Exactly.
decompensation in their autonomic. So I think that was a mantra that helped me get through residency a little bit. Like when I would get a consult, I was like, "Oh, this is nonsense," and
Yeah.
I'd be like, "Maybe there will be something that I can help with." And that was the
Yeah.
only way I could make it through, because otherwise I would just be hating everything.
Yeah. Yeah. And yeah, it's not that I don't understand. It's not that I expect our residents, at 2
Yeah.
a.m. Okay, yeah, you can be
Right.
bothered. It's okay.
Yes.
That's human. But
Right.
then all right. Then now you're in the room. There's a patient there. It's
Right.
time to really ask some questions and figure it
Absolutely.
out.
Yeah. Yeah. And I know it's easy to, especially when you are on the hospital service, to gripe and bellyache about uh, a lack of perceived effort on our colleagues' parts. But I think
Mm.
in reality it is, and it kind of comes back to this, to emphasize the education aspect, so that people are aware, like, oh, well, I should be thinking of X, Y, and Z. These are a few things, screening tests I can do, especially in hospitals that are short-staffed on neurologists, or maybe don't even have neurologists at all,
Yep.
to kind of help you get through the very early steps of the evaluation.
Yeah. And I talk with our residents, and I know that this is not something unique to me, but
Hmm.
when we're getting a consult, it's somebody that's asking for help. and
Right.
and I think that as neurologists, we should have a lot of pride in what we do. And this goes
Hmm.
back a bit to what I said at the beginning is, this is it's a skill, right? It's not doing a lumbar puncture, it's not doing Botox, it's not doing a
Right.
procedure, but there is a real hard skill.
Yeah.
And that's what I'm trying to teach in the book,
Yeah.
that we have from our training.
Hmm.
And to not sell ourselves short when we go in the room, and that thought process, going through the history, going through exam,
Right.
identifying the clinical syndrome, that is true expertise and something that's
Yeah.
honed over training, something that needs to be done intentionally.
Right.
And that was, maybe one other component to the impetus for the book, was that I found that a lot of our, the students, or a lot of our residents, um, they were doing this, but they didn't realize it. They weren't doing it, they weren't intentionally setting out to do
Hmm.
it. And they weren't really codifying it in their mind. And I thought, okay, if I could attempt to,
Yeah.
have people do this intentionally,
Hmm.
and with intent, and practice it, um, then, maybe that will help their training, much like you would never, if you're a musician, and,
Right.
and I play cello. And so,
Hmm.
started when I was a kid, you would never just sit down and start playing. You could,
Right.
but you're not going to be very good at it, and you're not really going to progress very far.
Yeah.
But if you really focus on the methods and the process, there's a reason why people do scales and do these sort of reps, right? If you're playing sports, you don't just go out and play basketball. The practice isn't just, 10 guys on a court going back and forth. You're practicing drills, you're practicing different components of it. And in neurology, do we really do that? Is our curriculum for medical students, is our curriculum when we have internists, or psychiatrists or family medicine, future family medicine doctors, or for our own residents, are we intentionally trying to break that part down into different discrete components to further the training? And it's something I think about when I'm on service. And again, I'm not saying the book does that for everybody, but it was a thought that I had in mind when I thought, is this a book that might be worthwhile, that people might actually think helps them in their clinical practice?
I think it will, and I think even as a neurologist, again, I will say all the same, not terribly far out of training, although I am getting some gray, but I think that this, even in just, I've read about half of it so far, and I think it's good, like you said, to examine our own thought processes as well, even if we're, somewhat experienced neurologists, so that we can, because the further you get away from that initial training part of your education, it becomes one of those things that you do automatically. And,
Right.
How can I best communicate this to someone who doesn't speak the same language that I do clinically?
Yeah.
And refamiliarizing yourself with those very basic steps to get someone on the right path so they too can reap the benefits of creating this neurologic framework.
Yeah. Yeah. No, I agree 100%.
Awesome. Well, I want to thank you. Do you have any final thoughts? Anything else you wanted to share?
No, I think that we've really touched on a lot of topics. Maybe the end one, although it's a bit cheesy to end on, but it's too late. I've already committed to it. Is that I find neurology just fun, and I think that it can be fun if you have the tools, right?
Yes.
It's not fun if everyone else knows something or has the tools and you don't. And so, when I'm working with our, off-service rotators from medicine or our medical students, it's not fun for them if I'm talking with the senior resident and the junior residents even, and we're all part of a club and they're not.
Right.
Likewise, when someone calls a consult and we dismiss it and we kind of brush it off in the note, that's not fun to them. We're not including them. And so, what I try and meet people where they are. I try and see, for a medical student, what's their knowledge base, and then kind of bring them in from there. Consults, if they're silly, it's a time for education. For the off-service rotators, it's a time to give them the skills they think are going to be relevant for them to, to be able to see these patients in the future. And if we can't make neurology fun, we can't take the passion that we feel as neurologists and then make that an enjoyable experience for others.
Yeah.
We're never going to increase that at 2%. Hopefully the book is supposed to be fun. It's supposed to, be mysteries. It's supposed to feel a little bit like Sherlock Holmes, where, there's something that's happened. We need to figure it out, and that we can get there together. And no matter where the reader is starting from.
Yeah.
And so, maybe that would be what I would end on.
And I will say one additional, one final compliment, if you can stand it.
It's your podcast, so you can do whatever you want.
Well, I'll make it two. First, I know everyone's listening, but the cover has this beautiful Art Deco inspired picture of the brain from an artist, Aaron Michael D. Greiter. Am I saying that correctly?
Yeah.
And I'll include a link to that in the show notes, but it is beautiful. He has other organ systems as well, although obviously I'm biased. And then the second thing, the chapter titles are, And then the initial vignettes, they give me like very strong Oliver Sacks vibes,
Yeah.
which I very much, it gives you, like you said, that kind of like, a mystery is beginning, you
Yeah.
know? And again, it is that very Sherlock Holmesian vibe, you know? It's
Yeah.
like, the case is afoot. So I like, it's very like, they're very punchy openings. So, you know, a lot of neurology, you know, especially the big doorstopper texts have it, you know, just looking at them sitting on your desk is intimidating, right?
Yeah.
Like I know you mentioned Adams and Victor's in your book,
Hmm.
which is the one I used through most of residency, and you know Bradley's is even bigger.
Right.
And you know, even as a neurologist, looking at those, you're just like you just have like an internal sigh as you flip open to a chapter and be like, "Oh, these pages are so thin, so they can fit even
Yeah.
more
Yeah.
in here." Uh, but no, like I want to emphasize how digestible each one of these case vignettes are, and how quickly you can get to like, this was a myelopathy, this was a neuropathy, this was a brainstem syndrome, and you know it's very well put together, and it doesn't outstay its welcome in each case, so that even people who are only, let's say, passing, I don't know how they could be, but passingly interested in neurology could still maintain their attention through a case. So I just want to thank you again for one, for coming on, and two, for writing such an excellent textbook. I think it has good applications for folks all the way from, you know, med students, even in other specialties, you know, people who are working in neuroscience adjacent fields, all the way up through attending physicians, neurologists and non-neurologists alike. I think there's a role for it in everybody's library.
Great. No, well, thank you for the kind words, and thank you so much for having me.
Thank you. And if folks want to reach out to you, where should they track you down if you're
Oh,
wanting people to do so?
oh gosh. So you know, I guess I'm newly on social media on Twitter. I'll have to tell you, I have to pull up my Twitter profile to make sure I'm giving you the right name. It's Meltzer MD. So at Meltzer MD is probably a way to reach out. And you know, I'm always love to talk neurology. And so you can find me there. And I also have a link to the book on my Twitter page as well.
Excellent. I'll include a link to that as well in the show notes. And thank you again so much for coming on. I really appreciate the chance to talk with you.
Yeah, thank you.
Thank you, everyone, for listening. If you enjoyed this podcast, please rate, review, and share it on Apple, Spotify, or wherever you get your podcasts, and please subscribe for future episodes. You can reach me on Twitter at Dr. Kentris, that's DrKentris, or by email at theneurotransmitterspodcast@gmail.com with any questions or show suggestions. We'll see you all next time.